Good evening, everyone. On behalf of Zorvia Healthcare, I warmly welcome respected Dr. P.C. Mahapatra, sir, and all our esteemed doctors to episode 2 of our masterclass in obstetrics and gynecology, Solving Clinical Dilemma. Today's topic is also equally very interesting, that is hypertensive disorder in pregnancies. In episode 1, Sir has shared invaluable lessons from his clinical journey, reminding us that experience is often the greatest teacher, and that too from the teacher who is the par excellence, that is PC Sir. Today, we take that learning forward into an important and challenging area of obstetrics practice, that is hypertensive disorder of pregnancy, solving a clinical dilemma. We are privileged to once again learn from Dr. Mahapatra sir from his vast clinical experience and wisdom. Thank you all of us for joining us this evening, and I would request Samiji to please quickly run our corporate video.
Healthcare today is evolving faster than ever before. New challenges, new expectations, and a growing need for therapies that are innovative, accessible, and focused on improving patient outcomes. It is this need that inspired the creation of Zorvia, a new age healthcare organization built on science, rooted in trust, guided by purpose, and committed to making a meaningful difference in patient care. At Zorvia, we believe that meaningful healthcare begins with understanding the needs of both patients and healthcare professionals. This belief drives our commitment to deliver trusted therapeutic solutions across diverse areas of care, supporting healthcare professionals across a broad spectrum of care, from infection management and respiratory health to diabetes, cardiovascular, and metabolic care, and across specialized areas including gastroenterology, women's health, pediatrics, and pain management. Zorvia is building a diversified portfolio designed to address evolving healthcare needs across every stage of the patient journey. At the heart of Zorvia are three defining strengths: deep therapeutic expertise, helping address evolving healthcare needs through focused scientific understanding and relevant therapeutic solutions; science-driven innovation, transforming research, insights, and clinical understanding into therapies that create meaningful impact; and a patient-centric approach, ensuring that every solution we bring to healthcare professionals ultimately serves the needs of patients. Together, these pillars shape our commitment to advancing healthcare with purpose and responsibility. Today, Zorvia's commitment towards healthcare takes an important step forward through a strategic co-marketing collaboration with Eris Life Sciences. This collaboration brings together Zorvia's deep understanding of infection management and healthcare engagement with Eris Life Sciences' trusted portfolio and commitment to quality, thereby supporting healthcare professionals across critical care and anti-infective management. As part of this collaboration, Zorvia will now promote the complete portfolio of Eris Life Sciences critical care and gynecology portfolio alongside its existing offerings. This will expand Zorvia's therapeutic reach, enhancing our ability to engage across a wider spectrum of patient needs. At Zorvia, our journey is guided by a simple belief: healthcare should be innovative, accessible, and patient-centric. As we continue to grow and build meaningful partnerships, our purpose of shaping the future of healthcare remains unchanged. Zorvia Healthcare, where healthcare is redefined with trust, innovation, and accessibility.
Thank you so much. Indeed, Zorvia, here the healthcare has been redefined with trust, innovation, and accessibility. So thank you so much. And then I would request our medical advisor, Dr. Sanjay Navle, to please quickly, take the session forward. Thank you so much, sir.
Thank you, Allah sir. So it is our privilege to welcome Dr. P.C. Mahapatra sir, a passionate teacher and eminent expert in the field of obstetrics and gynecology. As a distinguished faculty for today's master class, with his extensive clinical experience and expertise in this field, Dr. Mahapatra sir brings a valuable insight into the practical management of challenging clinical scenarios, and his ability to translate complex clinical concepts and scenarios into practical and simple evidence based decision making makes this session a particularly relevant for the practicing gynecologist. In this episode 2 of this series of masterclass in obstetric and gynecology from basics to advanced, Dr. Mahapatra sir will address the important topic of hypertensive disorder of pregnancy, solving clinical dilemmas. This session will focus on the clinical challenges and the evidence-based approach to the management of hypertensive disorders. So over to you, sir. Mahapatra sir.
Thank you. Thank you, Team Jorvia, Sanjay, Allah, and the whole team of Jorvia for this episode, second episode in gynecology. I extend my best wishes and all my love and affection to the viewers of this particular episode, my colleagues, my students, my grand students, and my fellow members of gynecology across the country and abroad. I think at the outset, I must appreciate the mission of Jorvia, that you are not selling medicines. I think your more important part is education, medical education and academics. And that is very, very important. Right from the beginning, when you started this company, a very new company started, and immediately within months, they decided to spread knowledge and update scientific acumen for all the gynecologists across the country. And that's why I think from my side, I extend all my best wishes to you for the growth of the pharmaceutical company in terms of business as well as in terms of scientific endeavor for that also. Believe me, I am a man of science, and that's why I am a teacher for the last 45 years, and that's why I want that if with this activities my students will be benefited, and that's why that will give a great solace to my mind and a great confidence and happiness to me over the years. Well, I bring greetings from the place of Lord Jagannath and welcome again to the masterclass in obstetric and gynec from basic to advanced, and the focusing attention on a very important topic. Each episode I will select some topic which is really of clinical relevance, and as a clinician's perspective, not as a purely academician perspective or a research perspective, but as a clinician's perspective, I will try to elaborate something and give you something which will benefit all of us as a clinicians for that also. And that's why today I've selected a different topic which is very common. I think in medical science, particularly in all fields of the medical science, including the gynecology and obstetrics, day in and day out the concept is changing. The different diagnostic armamentarium is changing, and the management protocol is also changing. And therefore, it is absolutely mandatory that the clinicians should update their knowledge if they want to grow and at par with the recent advances and particularly scientific innovations for that. And that is the purpose of these particular episodes for that. Believe me, as a teacher for the last 4.5 decades, science is growing in such a manner, I feel that I know less than 1% of this subject. And whatever I know, I think I will try my best to share with you what are the evidences involved in that particular topic for that also. Again, I congratulate the team Jorvia for their initiative, educational and academic initiative, and Their theme is Strong Path Towards Good Health. And I have given a different terminology for Jorvia as regards this masterclass. It is a jest of reproductive value, innovation, and acumen for that. And therefore, without any further delay, let me come to the topic of very important concern, hypertensive disorders of pregnancy. Well, at the beginning, I've told that yes, I will not tell about the details of the changing scenario of hypertensive disorders of pregnancy, some literature evidences imposed on that, and what are the changes for that, but mainly focused on the clinical dilemmas. And there are a lot of clinical dilemmas in relation to this particular entity, which is very common day in and day out. You are covering that. And therefore, I think if something I can give you relevant with a clarity, I think that will give a great happiness to me. Now, hypertensive disorders of pregnancy. The terminology itself, I will come to that. The terminology itself has a lot of evolution starting from my studentship till date. But overall, this particular entity is a significant attribute to maternal and perinatal outcome. There is no doubt about it. Gone are the time when the three pillars of maternal deaths across the country are hemorrhage number one, sepsis, and then hypertension. I think now the situation is changed. The scenario is completely changed. From 500, 700 maternal deaths, we have come to about 87. And of course, in different states, more less than 100 we can be able to come. I will give a credit to my obstetricians across the country, as well as the government policy, starting from the institutional confinement to the different medications and therapy, emergency obstetric care, and everything for that is contributing for that. And now, the recent surveys, no more hemorrhage is the leading cause. The hypertension has come to a high limelight for that. Hemorrhage gradually has come down, but I think bringing more light on the hypertensive disorders of pregnancy. And that's why it is very, very important in this particular episode to say that is really significant to the maternal and perinatal outcome also. It still remains as a disease of theories. We know the different theories of eclampsia and preeclampsia, but hypotheses abound, facts minimally. Pathophysiology is extensively studied, but least understood. We have grown in the concept, but still today, unfortunately, due to some reason or other, we are not able to pinpoint the pathophysiology for that. And this is a disease which is not limited to the uterus. It is a multi-organ and multi-system dysfunction. Pregnancy involves many changes in the various systems of the body, and the deviation when the hypertensive disorders of pregnancy occurs, it is a multi-organ and multi-system dysfunction. The spectrum of disease and level of care are also completely different for that. And as far as the treatment is concerned, one has to balance between these two, combine between these two, a supportive treatment and definitive treatment for that. In spite of some individual variability and unpredictable outcome, we will try to address this issue as rational and as scientific as possible for that. And therefore, there are many researchers with only when the research comes to practice, we clinicians are happy about it and we utilize it and we are the users and we say that yes, this is working, this is not working from that. So overall, this hypertensive disorders of pregnancy is from clinical syndrome to wide spectrum of manifestations in the various organ systems. That is very, very important for that. Now, as far as the causation is concerned, Pritchard, long back, when I was a student, I think this particular version was there in the books. Presence of chorionic villi in some way in some women incites generalized vasospasm. So the pathophysiology is a vasospasm. The generalized vasospasm is the main pathophysiology of this entity. And why this occurs? It is the presence of chorionic villi. In some way, in some women, not all women, incites generalized vasospasm for that. Now, therefore, the key issues, I will just go accepted classification and definition. Now, the accepted classification and definition, there is an enormous change for the last few decades. When I was a student, we were reading toxemias of pregnancies. Toxemia is no more applied for that. Then there came pregnancy-induced hypertension. There's a lot of debate regarding the reality of the pregnancy-induced hypertension for that also. And therefore, the terminology should be very apt for that. And there, the gestosis society is there. Gestosis of pregnancy is another definition for that also, and terminology for that also. And of course, the classification, accepted classification, there is a lot of changes along with the definition for that. But standardized definition accepted by all clinicians, I think now in the present status, is hypertensive disorders of pregnancy. No more toxemia, no more PIH for that also. Now, pathophysiological basis, there is a lot of changes in current thinking, but ultimately it is the vasospasm which is there for that also. And what is responsible? Whether it's the genetic factors, whether it's the vascular factors, whether it's the immunological factors, there are various theories applicable for that. And prediction and prevention is $1 million question for that also. There are various predictive variables associated with it, but nothing is significant for that. And of course, we know the predictive value, then we can have a preventive aspect for that also. Can we prevent? Many people ask, can we prevent? Can you completely eradicate hypertensive disorders of pregnancy? No, it's never possible for that. If we can prevent eclampsia, we can prevent the degree of hypertension, but we cannot completely eradicate these hypertensive disorders of pregnancy. From eclampsia occurring, we can prevent at the stage of preeclampsia and treatment for that. Therefore, lot has to be thought about this particular entity and the way forward for that also, about the prevention and prediction for that. Now, supportive and definitive treatment. The supportive and definitive, I've already told there are two varieties. One is a definitive treatment and another is supportive treatment. It's a syndrome manifestation of the hypertension, the convulsion, and particularly the various systems affection for that also. And therefore, Pritchard, which tells that presence of chorionic villi is important. It's not the fetus. Earlier it was called the presence of fetus, but it has been seen that simple chorionic diseases like molar pregnancy without a fetus can give rise to this particular entity in a much more earlier phase in pregnancy further. Therefore, presence of the villi is important. Chorionic villi, the syncytiotropoblast and the cytotrophoblast, mainly responsible for this entity further. And therefore, it is obvious that the definitive treatment will be termination of pregnancy. But for antihypertension, for hypertension, for convulsion, the role of antihypertensive and anticonvulsant cannot be ruled out. I think these are supporting. Therefore, the two main aspects has to be dealt with. So therefore, the control of hypertension, the control of convulsion, and optimum time and mode of delivery are the main three challenges before the clinicians, practicing clinicians. As far as management is concerned, I think every clinician should target how you control the hypertension, how you control the convulsion, and decide for the timing and mode of delivery, not only for the maternal survival, but now in the present status, we have moved one step ahead of recognizing the fetus as a second patient and the right of the fetus to live, and therefore the time and mode of delivery should be balanced so that we can have a good maternal, optimum maternal as well as a perinatal health, and that is the motto of every clinician for that. There are a lot of controversies. I think debates will be there, differences will be there. If you see the guidelines, there could be debate for that also. But for the clinicians, I think whatever is applicable, I think that is mandatory for that. An ultimate aim is to have an optimum maternal as well as perinatal outcome. Now coming to the classification for that, as I have already told, the classification has become, various classifications have gone through that. but the task force group of American Gynecological Society, the task force group, and took a long time. And 213, they decided that yes, we should have these four types of hypertensive disorders of pregnancy. First is gestational hypertension, which means that previously it's a normotensive or in the first half of pregnancy normotensive, and particularly it arises in the second half of pregnancy, and it is limited during pregnancy and immediate intrapartum and immediate postpartum period, and then maybe after 2 weeks to 3 weeks, maximum after delivery, it becomes normotensive for that. And it's not associated with proteinuria or other non-proteinuric evidences leading to the severity of the diseases for that. And therefore, it is absolutely a very good entity which is very common for the clinicians for that. Hypertension, and the definition of hypertension, I will tell how you say that hypertension, what is the level of hypertension you say. But the hypertension without any proteinuria, restricted to second half of pregnancy and arising de novo in pregnancy and just disappearing after that, although that could be 16% of the cases can go for a residual hypertension for that. Second most important is a preeclampsia syndrome. Preeclampsia syndrome are one spectrum of entity where along with the hypertension of various varieties, degrees, I think the proteinuria is a very important part for that. And also there could be other evidences, manifestations of that attributing to preeclampsia for that. I will just enumerate within a couple of slides for that. And eclampsia, of course, convulsion and coma, as we know, that is still there for that. And I thank the obstetricians across the country that certainly there is a reduction in the incidence of eclampsia. Although not whole of hypertensive disorders, we have been able to abolish for that. And this is because of good knowledge, good endeavor, and scientific management so that we can prevent from severe hypertension to mild and moderate hypertension, from eclampsia to preeclampsia. The third variety is a chronic hypertension. These are already hypertension, patient is hypertensive, and nowadays it's very common with the changing demographic, with the late age of marriage, with the first pregnancy occurring after 35, and prone to having a hypertension comorbidities associated with it, either hypertension or diabetes, they enter the pregnancy. And when the pregnancy is there, we know that is a pregnancy, there occurs vasospasm. And the affections of the chronic hypertension known patient could be aggravated during pregnancy. And therefore, it could be entered in the third last part, which is superimposed preeclampsia and eclampsia. A chronic hypertension superimposed with the preeclampsia is also there in a case of chronic hypertension at any point of time, and preferably in the second half of pregnancy. So these are the accepted classification of hypertensive disorders of pregnancy. Now, apart from it, there are some specific entities the clinician should know. Delta hypertension. I think hypertension, we say that 140/90 is the cutoff limit for that. Another time when 30-15 rule has been there, more than 30 over the baseline systolic, more than 15 over the baseline diastolic, then we can say that it's a hypertension. Or mean arterial pressure beyond a critical limit, we call it as hypertension. So this is the definition, but absolutely for the clinician simplicity, we are clear. There is no controversy that the systolic cutoff limit is 140 and the diastolic cutoff limit is 90. Well, where from the delta hypertension comes? I think this is an entity where even with 140, less than 140 also, if the baseline is less, say for example 100 millimeter is the baseline level, 130 becomes abnormal, and therefore it has been seen that even without any evidence also there is some cases which manifest the systemic abnormality and disturbances as caused by the hypertensive disorders, and this is called a delta hypertension. Now, residual hypertension is again, we cannot know, as I have already told about the hypertension, gestational hypertension. Ultimately, after delivery, within 1 week or 2 weeks, the blood pressure should return to the normal. But there are some cases where the residual hypertension continues, and that percentage is about 15-16% of cases. One of the most grievous and emergency situation is a HELP syndrome. We know that HELP syndrome, all of you must have seen at least 1 or 2 cases of HELP syndrome in your life. So hepatic, I think, enzyme, elevation of the hepatic enzyme and liver enzyme, platelet hypertension, platelet count, and the hypertension combined entity will give rise to HELP syndrome, which is an acute emergency, and the treatment needs a special, I think, entity, even to the extent of a high dependency care or obstetric ICU for that. The last thing, preeclampsia, eclampsia remote from TORM. We know that the preeclampsia, eclampsia, or hypertensive disorders of pregnancy are most manifested during the second half of pregnancy, or mostly in the late trimester, third trimester of pregnancy for them. But there are some entities where recently, with the last 1.5 decades, this has been reported that this is a different specific entity where preeclampsia and eclampsia remote from TORM. Leave aside the molar pregnancy, leave aside the multivital gestation, leave aside the other problem leading to the hyperplacentosis conditions for that. But in a normal singleton pregnancy also, there is some entity which is linked, that the hypertension could be there remote from TORM. At 28 weeks, 30 weeks, 32 weeks is the first time you develop hypertension for that also. So these even at 24, 26 weeks also hypertension can be seen. And this has been linked to an entity called Apla syndrome. And this Apla syndrome is a link, particularly the syndrome linked with this preeclampsia, eclampsia remote from TORM, which is affecting the fetal survival and affecting the perinatal outcome for that. Now then, diagnosis, blood pressure measurement. I'm not going to speak about how in which hand you do it, in which how is the length of the cuff, and in a sitting position, supine position. All of you are well versed with that. But 140/90 is the cutoff limit for that. And NICE guideline divide into mild, moderate, and severe as per the different levels of the cutoff limit. But basically 140/90 is there. And remember, we are not, this is considered the mild, but severe is 160/110. It's more important to think about severe rather than mild to moderate for that also. But severe and moderate are most important distinction of hypertension. 160/110, normal cutoff limit is 140/90 millimeter. And same thing with the proteinuria, 24-hour urine protein more than 300 milligram. And if it is severe gestational hypertension or severe preeclampsia, I think more than 5 gram is considered as a severe. And urinary protein creatinine ratio has also been compared and correlated with that. And more than 30 milligram per millimoles is designated as a cutoff limit for that. Now, therefore, as a clinician's emergency or entity, we most important give rise to importance to severe preeclampsia, and the diagnostic criteria I've already told, 160/110. And normally we say definition of hypertension, it's not a single reading, it could be a white coat hypertension, and therefore you have to take in 2 different readings for that. But remember, if on the one reading you find a level beyond, level above the severe hypertension, you can say that it is a case of hypertensive disorders of pregnancy, even if you cannot level it as a case of severe hypertension. Whereas, if you're a single visit, single recording, first recording you find 140/90, you have to confirm after a variable period and record to see that it is staying there or it is coming down for that. And it is applicable for a mild to moderate variety to level it as a case of hypertensive disorder of pregnancy, not for the severe variety. And proteinuria of 5 gram or higher in 24-hour urine or 3 plus is considered as the severe hypertension. Apart from it, it is not the proteinuria. Earlier we were thinking that proteinuria, antenatal care, I have seen the evolution of antenatal care. The purpose of the clinicians in the OPD, measure the blood pressure, see whether there is a pedal edema or not, And apart from finding out the uterine size, fetal heart sound, and presentation position, you do one investigation, that is a urine albumin for that. Now, if albumin is there, then you can say that it's a case of preeclampsia. But apart from it, I think the other criteria, which is very, very significant clinically, to the clinicians, is oliguria. Oliguria of less than 500 ml urine in 24 hours. If there is a fetal affection, IUGR. If there is a cerebral or visual disturbances, if there is a pulmonary edema or cyanosis, epigastric or right upper quadrant pain, giving rise to liver impairment and thrombocytopenia. These are some additional factors as a diagnostic criteria to designate it as a case of severe hypertension. We have been reading and teaching students about the Eden's criteria. Williams has given a beautiful example of Eden's criteria and all that. And this is almost saying that normally the severity of hypertension is diagnosed because of this. Now, pathogenesis. A little bit of pathogenesis, I'm not going to tell about the details of it. Prostacyclin deficiency, placental vascular abnormality, and immunological factors are the main three causes which affects placental ischemia. And the placental ischemia is resulting in vascular endothelial cell dysfunction. The main thing is vascular endothelial cell dysfunction and endothelial cell damage, which acts in a cyclic manner again, ultimately giving rise to the placental ischemia. And that is the main thing, origin of pathogenesis of hypertensive disease of pregnancy. Now the symptomatology again, what are the affections of that? If there is a vascular endothelial cell damage, it can affect the uterine environment, the placenta, atherosis, ischemia, giving rise to fetal affection of IUGR and fetal distress. It can affect the liver, periportal hemorrhagic necrosis and liver enzymes, increase of the liver enzymes. It can affect the kidney, giving rise to GFR, GFR reduction of the glomerular filtration rate, glomerular capillary endotheliosis, and proteinuria for that. And the renal blood flow will be impaired, glomerular filtration rate will be impaired, giving rise to oliguria and thereby increase in the renal markers like a creatine and uric acid for that. For the blood vessels, the vascular permeability is increased so that edema is manifestation, and because of the vasospasm and vasoconstriction, severe hypertension is seen. So go to the brain, central nervous system, fibrinal changes, headaches, seizures are the main, and that is the cause of seizures or convulsions in a case of eclampsia. When coming to the blood, the thrombin activation, fibrin deposition giving rise to DIC, and platelet activation giving rise to thrombocytopenia, erythrocyte destruction giving rise to hemolysis, and ultimately combined with the liver and the blood abnormality manifests the syndrome of HELP syndrome. Now coming to the prediction. There are some predisposing factors. I think for the clinicians it's important. It's a disease manifested in first pregnancy. So the chorionic villi of the first pregnancy is important for that also, and therefore it is more manifested in the primary gravidae. And therefore genetic predisposition is another factor. Dietary factors and relationship with the calcium and other diet related. It is of course a disease more common in low socioeconomic status. Hyperplacentosis, I have already told, the metabolic syndrome or disease, diabetes mellitus, renovascular disease, and I have already told about the chronic hypertension, the superimposition gives rise to preeclampsia. Now the predictors of PIH. Upward trend in BP serial, mean arterial pressure more than 90 millimeter mercury. We have got various tests for that. Angiotensin test, a pressure test, rollover test, which are almost about obsolete now for that. And of course with the biochemical thing like fibronectin assay and the alpha fetoprotein, most important is the Doppler velocimetry. Doppler velocimetry in early pregnancy has been proved to be one of the very important predictors of PIH, and therefore this particular entity can be diagnosed during the 12th to 13th week scan when doing the NT scan. Long back with the NT scan, we are doing the double marker test. Now we combine with the pentamarker test. Prediction of preeclampsia is also an important aspect along with the aneuploid diagnosis. So apart from the aneuploid diagnosis, this importance of preeclampsia eclampsia prediction is important. And PLGF is a very important molecular biochemical factor. Estimation of that PLGF with or without combining with the other markers like histiol and the beta HCG can be a reflections of predictions for PIH in that particular individual for them. And of course, the way in which the biophysical parameters like sonography, fetal medicine has developed in such a way that right from the time of early pregnancy, we can diagnose by doing a fetal Doppler velocimetry. Now coming to the prevention. The levels of prevention are three primary prevention steps taken to avoid the disease. Eradicate pre-eclampsia hypertensive disorders of pregnancy. It's never possible because we don't know the cause. Secondary, arresting the disease process. We know the cause is particularly the vascular part and the vascular endothelium, and arrest of the disease process from severe preeclampsia or eclampsia, we can reduce it at the stop at the level of the moderate hypertensive disorders of pregnancy. The modalities are variable, and of course, it needs a continuous evaluation and a periodic evaluation with the patient. And future research, till future research is there, till we find a new molecule, you take one molecule and prevention will be there for that also. We're waiting for the pharmaceutical company to find out an innovative molecule for that. Now, as far as the clinicians are concerned, basic principles before the clinicians. I've already told, prevent convulsions, control hypertension, and delivery. And what are the drug options? Prevent convulsions. There are a series of things where Indians have also contributed. When we were students and then in the early part of our profession, the lytic cocktail therapy in eclampsia was proved to be one of the best things for that. Apart from it, there are various regimens, the Lin regimen, diazepam regimen, phenytoin regimen, barbiturates and all that are there. But Richard's Mark-Sulf regimen has proved the test of time for that. No more we are dealing with other regimens. We have accepted this Mark-Sulf as a really only options for prevention of convulsion in a case of hypertensive disorders of pregnancy. Initially, there was a lot of apprehension of using for that also. I remember we have given a thesis to one of our postgraduates. At that time, the Mark-Sulf was not available. And only one company was manufacturing Mark-Sulf in Bengal Chemical and all that. It was not there manufactured because it's a cheaper drug and Mark-Sulf was not available. We had to bring from the company and started the therapy for that. Now, of course, it has been available by a pharmaceutical company also, either pure Mark-Sulf in dilution concentration or in dilution or in form of a drip. Now, some of the companies are manufacturing that and supply. And people are using, we are using that also. Regarding the control of hypertension, there is a lot of debate, which is a very important antihypertensive in pregnancy for that. Out of all the antihypertensive, the hydrolazine has been proved one of the superior and evidence-based and scientific for that. But somehow I know hydrolazine is not available. No pharmaceutical company is manufacturing hydrolazine, and particularly the parental hydrolazine is more important for that also. And then the next comes about we're using about the methyl dopa. Methyl dopa was also a very good drug and safe drug in pregnancy for that. But the only problem of methyl dopa is that it is acting centrally and the onset of action is delayed up to about a week. So it cannot be used to combat the crisis for that. For maintenance therapy, you can use the methyl dopa. And of course, methyl dopa, 8 hourly, you can give it for that also. But no more gradually, these two, hydrolazine and methyl dopa, has almost become obsolete in our obstetric practice. And then we are really confined to two drugs, what is a labetalol and calcium channel blocker or nifedipine. Nifedipine is a really close to obstetricians because they're using it for dual purpose for that. For preterm labor, calming the uterus, as well as preventing convulsion for that. Balancing the hypertension for that. So still it is being used, calcium channel blocker, nifedipine and labetalol for that. But remember, we have seen the nifedipine used sublingual at the time of crisis when it shoots up we use the sublingual for that. We have seen really fatal reactions out of the sublingual, and therefore it is almost banned. Don't use sublingual nifedipine for that. You can use the oral, and that too for maintenance purpose. You can use the sustained release preparation for that also. And labetalol, of course, either parenteral used for emergencies, and of course the oral tablet for maintenance of pregnancy hypertension to control for that. So this is the summation about the supportive treatment for that. And apart from it, the surveillance and monitoring is important. If you find that you need to have a fetal outcome, perinatal outcome, so you have to have the continuation of the pregnancy for that. And therefore, a case of hypertensive reverse of pregnancy, surveillance and monitoring till the delivery is absolutely important for that. And delivery, the determinants are, what are the determinants? When you decide the decision for delivery is mainly either a gestational age, because gestational age we are interested for fetal outcome, and the cutoff limit for the fetal outcome is about 34 weeks for that. So we are targeting for 34 weeks as a cutoff limit for the gestational age. But even at 32 weeks also, now with the improved neonatal gadgets available for that, if the patient warrants, the condition warrants, the severity of the disease is there, we have to terminate the pregnancy even before that also. But ultimately, no more 37 weeks has been taken as a term, though we regard that as a term, but fetal survival is optimum up to about 34 weeks. Even with a little warmer and all that, they can survive without an NICU. So therefore, gestational age is one. Severity of the disease is another factor. You cannot compromise. You cannot at the risk of the patient, mother, you cannot aim at continuing the pregnancy for that also. The severe, particularly for fulminant preeclampsia or eclampsia, you have to terminate the pregnancy, whatever may be the gestational age for that. And therefore, the fetal and maternal status are very, very important. Same thing for the fetus also. If the fetus is an IUGR, it's not compatible. Even if it's a low birth weight fetus in IUGR, we have to deliver it so that the NICU facility, the pediatricians, neonatologists can take up and all that. And I think nowadays there's a great change in the survival of the neonate as far as the weight is concerned for them, because of the nursery capability available starting from level 1 NICU to level 3 NICU for them. So therefore, management options, the goals of therapy, again I will highlight, remember all my fellows, prevention of convulsions, prevention of complications, delivery of a surviving child with minimal trauma to the mother for that. That should be the goals of therapy. And maximizing duration of pregnancy with minimally jeopardizing the mother and fetus. You are at liberty to prolong the pregnancy for the perinatal outcome, but not at the cost of the mother and fetus. Maternal surveillance is also important along with the fetal surveillance. Continuous fetal surveillance as well as the maternal surveillance should be there for that. And supportive and definitive therapy again are the two main mantras for hypertensive reverse of pregnancy. Now, control of hypertension. Again, when we come to the control of hypertension, there are two main varieties I can find out. Whether the control of crisis, hypertensive crisis is one, and management and use of hypertension in long-term use for that. So in case of eclampsia or a fulminant preeclampsia or in a HELP syndrome, I think the crisis management is there. So you have to find out a drug which helps in crisis management. And therefore, ideally, scientifically, we always teach students, and we were reading that hydrogen is one of the best drug for that, safest drug, which is because it doesn't impair the renal blood flow. And control of crisis is immediate for that. And now, for this control of crisis, again, the calcium channel blocker has become used. The injectable labetalol can be of use for that. And long-term use, the oral tablet and calcium channel blocker combiningly or alone can be used for control of hypertension. The choice of agents are you. You decide. So the antihypertensive drugs used in pregnancy, mainly the mechanism of action is vasodilators, nifedipine, nicardipine, hydralazine. drugs that decrease the cardiac output, the beta blockers, the labetalol alpha beta blockers, and centrally acting is the methyl dopa. Now, what should be the profile of an ideal antihypertensive? How you select that? I want to select an antihypertensive which preserves the GFR and renal blood flow, few or no drug reactions, little or no potential for exacerbation of comorbidities, rapid onset and offset of action, minimal hypertension and overshoot, minimal need for continuous BP monitoring and frequent dose titration. These are my criteria to select an ideal antihypertensive in this hypertensive disorder of pregnancy. And treatment of acute severe hypertension is a crisis, and therefore the crisis drug accepted is hydrogen, but parenteral labetalol is the second line drug which is there. Oral nifedipine used with caution, because I've already told short-acting nifedipine is not approved by FDA for managing hypertension, neither the sublingual preparation because of sudden hypotension. The alternative is not non-responders. Sodium nitroprusside may be used in their case, and we have used the sodium nitroprusside in some cases in non-responder of hypertension. And these are the mechanism of action of the different hypertensive, starting from methyl dopa in the central action, to the reserpine, propranolol and other beta blockers, the kidney level, to hydrogen, minoxidil, nitroprusside, diazoxide, calcium channel blockers at the vessel wall further. So, choice of antihypertensive, again I say that I forget about this. Labetalol 20 mg IV bolus, then 40 mg 10 minutes later, 80 mg every 10 minutes for 2 additional doses to a maximum of 220 mg. And nifedipine 10 mg, repeat every 20 minutes to a maximum of 30 mg. Cautious use with magnesium sulfate can see precipitous blood pressure drop. Short-acting nifedipine is not approved by FDA for managing hypertension. And rarely in non-responders, when everything fails, sodium nitroprusside can be used with 0.5 mg per kg per minute to a maximum of 5 mg per kg per minute. And fetal cyanide poisoning may occur if used for more than 4 hours for that. And that's a really a dangerous side effect for that. Now coming to the control of convulsion. I've already told the choice of anticonvulsant in the present era is the first modality, first drug is Maxol. The second drug is Maxol. The third drug is Maxol. And the duration of use, you know the Maxol regimen, how it started. At the start with the 4 gram in a case of severe preeclampsia and eclampsia. It is not used in a case of mild or moderate hypertensive disorder of pregnancy. It is only limited to severe preeclampsia and eclampsia. And there, the treatment starts from the regimen is there, about 4 gram initially IV and 5 gram in each buttock in the initial 0 zone. And every 4 hours, you give 4 gram IM for that and continued up to 24 hours. And choice of anticonvulsants in between, you see the reflexes, you see the respiratory, you see the urine output, and you can abandon because of the Maxol toxicity could be there. So this is the duration of use, you must use it. And the toxicity and side effects is well known, and the antidote calcium gluconate can be given for that. So therefore, I always again reiterate choice of anticonvulsant in preeclampsia, eclampsia is magnesium sulfate for that. And it is proved to be superior till date. Now coming to the definitive therapy, termination of pregnancy. It's very easy to call it termination of pregnancy, but how the modalities, the routes of termination, induction, yes. If you find an indication of the induction, one comes as a hypertensive disorder as one of the indications for the induction of labor. The induction, the choice and method varies. It depends on the cervical assessment, the cervical status, duration of pregnancy, and the fetal status for that. And therefore, if everything is really genuine and is approved to be in induction is successful by Bishop scoring, by finding out that the fetus can withstand the labor process, I think you can do induction. The various agents for medical induction, prostaglandins has come out in a big way for that. Earlier we are giving these oxytocin drip, and now mechanically the cervix is unripe. You start ripen the cervix and then start induction is definitely a place in hypertensive disorder pregnancy. more so in the mild to moderate varieties. Now, place of cesarean section. Yes, of course, there are a lot of indications of place of cesarean for the fetal indications and for the maternal indications. If you do not wait, if it takes a long time in a case of severe hypertension or severe preeclampsia and eclampsia, I think it's better to do a cesarean section because termination of pregnancy is the definitive treatment for the hypertensive disorder. But if the everything is normal, like the pelvis is normal, the labor process is on, and already dilatation is going on for that, you accelerate, you augment it by doing an ARN and putting a drip for that. So that is a choice of the cesarean section for that. It should be decided on individual basis for that. Choice of anesthesia, and now all anesthetists are convinced that the regional anesthesia are best, even if in the case of eclampsia or severe preeclampsia for that. So that it depends on that, and it will be proved by the anesthetist that yes, they will prefer the regional anesthesia. And of course, in this delicate thing for that, you have facility for critical care and neonatal care, particularly in a severe hypertension, in a preeclampsia or eclampsia, facility for critical care and neonatal care should be available in that place. And therefore, if necessary, you can transfer that to that tertiary level for that. Now, what are the determinants, obstetric determinants? The duration of the gestation is important. More is the duration of gestation, better is the perinatal outcome for that. Severity of disease process, less severe is the disease process, better is the outcome for the mother and fetus. And of course, we have to consider these two main lives, the fetal status and maternal status. And our aim is not only to save the mother, saving both mother and babies are there. And therefore, the infrastructure, ultra function, and ancillary support staff could be there to achieve this particular goal for them. My dear viewers, with this brief introduction or overview of this hypertensive disorders of pregnancy, I know that you are clinicians. You have left your OPD or OT to join with me for that also. Let us find out some of the situational analysis and the clinical dilemmas, how we can solve it for that. Problem 1, 26. These are all real life situations I have faced it for that. The number of cases I put it few cases because of the time constraints. 26 years primigravida, conceived following investigation for infertility for 3 years. Booked case at 34 weeks of gestation. So the booked case presented at 34 weeks of gestation to the antenatal clinic with moderate pedal edema. Blood pressure was 146/94 millimeter mercury. Urine albumin was negative with a vortex presentation with normal clinical fetal growth profile. Everything is normal, corresponding to the 34 weeks of gestation and all that. And clinically, everything is normal. And with this, what investigations should you suggest and how you go ahead with this particular case? First of all, the diagnosis of hypertension. 146/94, the cutoff limit. But after a variable period, we have to again see whether it is there or not. If it's after 6 hours, it is there constantly with above 140/90, then of course our diagnosis of hypertension and hypertensive disorder is confirmed. And that too, urine albumin was negative, so that we presume that it could be a gestational hypertension. Maybe that our diagnosis can be foolproof after delivery and within a period that the normotensive interval will be there within 2 weeks for that. So in this particular case, what investigations should you suggest? The commonest investigation, I think, for the fetal thing, urine albumin has been done for that. You may do a quantitative estimation of albumin, but apart from it, you have to do a sonography for the fetal status to know the fetal status, and that will determine the management protocol for that. And therefore, confirmation of hypertension clinical is important, and whether hospitalization versus domiciliary treatment you do. I think these cases can be treated domiciliary also. In this case, may not be taking off an institutional confinement, but you do this particular case ultrasound for the fetal assessment. And two things in your mind occurs, whether continuation of pregnancy versus termination of pregnancy. We have already told that 34 weeks we can have survive the baby for that, but not in this particular case. As we prolong each week of prolongation, the percentage of survival will increase further. So if everything is normal, sonography, everything is interval growth scan, the fetal parameters are normal, daily fetal movement counting is normal, and on sonography also you find that this is normal, NST is normal. There is no indication for termination of pregnancy, although in this particular case it is a definitive method for that. Because by waiting policy, you can really improve the perinatal outcome. So these are the two things on the clinicians. In this case, continuation of pregnancy should be there. But how long? Again, that's a very important thing. How long you give it for that? And majority of the cases, we say that yes, 37 weeks is term. And up to 37 weeks, you continue. And then after that, you have to wait for spontaneous onset of labor or induction of labor. That's again a clinical dilemma. Normally in a hypertension of this standing and all that, if without any fetal compromise, fetal growth is normal, everything is normal, biophysical profile is normal, you can, if you can monitor it, you can wait for spontaneous onset of labor beyond 37 weeks. But if there is something abnormal occurs, the hypertension, the blood pressure is gradually not controlled with that, and there is a fetal affections for that, urine albumin is appearing for that, and of course in those cases you have to do termination of pregnancy even before 37 weeks for that. This is a point which everybody should remember. If everything is normal, you can wait for up to about beyond 37 weeks, 38 weeks for that. But normally, don't wait more in a case of hypertensive disease of pregnancy. And that will also depend on the cervical status, on the weight of the fetus. So these are the cases where the confusion occurs whether continuation of pregnancy versus termination of pregnancy. But in this particular case, if you continue the pregnancy for a few weeks, you are at an advantageous position for the fetal survival. Now, role of antihypertensive. I remember when there is a mild hypertension earlier, the recommendation was that just a tranquilizer, rest and all that. Now, the universal guideline recommendation in one mild hypertension also, you start antihypertensive therapy. Either a labetalol or calcium channel blocker, you can give it for that. And diuretics, say no to diuretics. There is no need of a diuretics here because we know that in a case of hypertensive disease, the vascular volume is reduced. I think it will affect the fetal placental circulation for that also. And therefore, unless it is an acute emergency, diuretics should not be used for that, excepting in a case of eclampsia or pulmonary edema, or in a case of severe fulminating preeclampsia, diuretics, don't give diuretics for that. Monitoring is very, very important. And monitoring methodology, luckily, we have got many gadgets available, and one of the most important gadgets is an ultrasound. And nowadays, it is very frequently used. No more, it is a 18 to 20 weeks TFA scan. No more, it's a 13 week scan and NT scan. I think interval growth scan has also been proved to be very important and superior to the clinical judgment for that. So monitoring methodology, starting from the sonography, the NST, to the clinical method of a daily fetal movement counting, you continue if you want to continue that. So diagnosed as a gestational hypertension, domiciliary treatment with periodic follow-up of frequent intervals, and continuation of pregnancy for better perinatal outcome. How long? I've already told you and explained how long. That will depend on the individual situation of the maternal and fetal status. And only tranquilizers, no diuretics, antihypertensives. No diuretics. Tranquilizer can be given. But antihypertensive in the current guideline, you have to give it for that. Salt restricted diet, again a debatable question for that also. Salt restricted diet or salt free diet for that. When we were students, lot of emphasis was given on salt free diet or salt restricted diet. Now studies have shown that it's not of much of benefit for that. Of course, the antenatal assessment, the periodic profile, periodic assessment is important. And then it continued spontaneous onset of labor at 38th week with vaginal delivery with medial episiotomy, full-term live male baby weighing 3.1 kg. So I want to say that these are the cases where presence of pregnancy is not an indication of cesarean section. There is a place for vaginal delivery for that. And these are the cases. where you can allow for a vaginal delivery and uneventful maternal perineal. So the message, mild varieties do have a favorable outcome for that. And no active intra-obstetric intervention necessary unless it's indicated, unless it's a progressive. Adequate monitoring for progress of the disease is important, and optimum antenatal care and intrapartum surveillance is the key to success. Problem 2. 34 years, gravida 3, para 2, leaving 0. At 36 weeks of gestation, booked case, normotensive, normal fetal growth profile, presented with reeling head and pain abdomen and loss of fetal movement. And on examination, I went. Patient was conscious, blood pressure 180 over 110, 18 millimeter mercury, edema, uterus was there, uterus 36 weeks, tender, FHS was there. And cervix was fully effaced or 3 centimeter dilated, small bag of water, head at -2, pelvis edema. Now, what should be the clinical work components? This is a case, I think, with these findings, you can say completely that this is a severe preeclampsia. Not only severe preeclampsia, but icterus is there. We think to exclude whether there is a HELP syndrome for that also. And therefore, this is a fulminant variety which has occurred. It was absolutely normal booked case, and then suddenly at 36 weeks, she developed that. With this finding, an onset of labor started. And what should be the biochemical investigation? Certainly, to exclude HELP syndrome, you do some liver enzyme study and platelet, but much more important for that. And how you proceed with obstetric management is already started. The labor process has already started, fully effaced or 3 centimeter dilated, small bag of water. I think augmentation of labor is important because we know that the definite treatment is a termination of pregnancy for that. And therefore, diagnosed as a fulminant preeclampsia with placental abruption and HELP syndrome. Sonography also reveals that there is a blood clot, retroplacental clot. Liver enzymes are increased and low platelet count. So these are biochemical pointers to HELP syndrome. The renal status and coagulation profile, you side by side do it, and requisition of blood transfer, because we anticipate in the case of placental abruption the PPH for that also. And of course, antihypertensive for crisis management has to be done, and anticonvulsant has to be done. And these anticonvulsant, nothing less than max out for that in a case of. And simultaneously to expedite delivery, you do an ARM. And ARM done, blood stain like a drain. A term live male baby delivered by vaginally after half an hour. Peculiarly, these are the cases that the expulsion process is much quicker for them. And there's a large retroplacental clot, PPH controlled by misoprostol, and uneventful recovery for that. So the message here, fulminant variety of hypertensive disorders not very uncommon. Fetal outcome, multi-organ dysfunction needing intensive care and monitoring. Active intra-obstetric intervention is mandatory for that. And it's a betinoid in obstetric practice in true sense. It is a black beast. Absolutely, it is unknown. Everything is normal. All of a sudden, an emergency. It's really a betinoid in obstetric practice. Problem 3, 19-year-old primary gravida at 24 weeks of pregnancy presented to the labor room with 3 bouts of convulsion. I am quoting this particular case before the sonographic era. And in the labor room, they present with the 3 bouts of convulsion. 19-year-old primary gravida, married 1 year ago, at 24 weeks. Blood pressure was 176, 118 millimeter mercury. And edema was there, pallor, urine albumin triple plus, but 3 bouts of convulsion. Uterus 20 weeks, tonically contracted, and FHS was not localized. And at that time, we didn't have any gadgets to know whether it's a fetus, live fetus, or a dead fetus, or something else. Cervix is long, os is closed. So, we diagnosed that this is a case of eclampsia. But it's an unusual case of eclampsia at 24 weeks for that. That gives us suspicion, clinical suspicion. That it could be molar, it could be a multifetal gestation or a hyperplacentosis. And this could be our clinical diagnosis. We think about it for that. And the investigation, if the sonography is there in the labor room, we can do the sonography immediately and come to know the diagnosis for that. Excepting doing a urine albumin and some of the blood test, we cannot do anything else for that. And the treatment modality, thinking about the treatment modality, and this particular case, what happened? We started anticonvulsant, antihypertensive. Immediately, Maxalf has to be given with calcium channel blocker. And luckily or unluckily, expelled molar tissue after 4 hours spontaneously. And the diagnosis is evident. And if in the present time, if this case should have been there, we should have done and confirmed it 4 hours earlier by doing a sonography. Patient have a profuse bleeding when patient went into shock and blood transfusion was done. Evacuation was done under anesthesia for that. And blood transfusion, prostaglandins at that time is supposed to was not there. Prostaglandin was just initially coming and discharged home after 1 week. So the message, think of GTD in hypertensive reservoirs of pregnancy in the first half of pregnancy. And therefore, you think about it. Problem 4. 28 years old, primary gravida, 32 weeks gestation, admitted to labor room with history of fever and convulsion in a comatose condition. Again, with convulsion, but fever is there. And on examination, blood pressure was normal, 100 by 70 millimeter mercury, pedal edema was there. Uterus 32 weeks, relaxed, cephalic, 5 out 5 FHS good. Cervix long, os closed. Urine albumin negative. We cannot think of hypertensive with the rest of pregnancy. Think something else for that. And it should be the clinical work of thinking our mind for that. And our obstetric management, what is the obstetric management? After the diagnosis, we can see for that. And therefore, what we done? Plasmodium, think of malaria, diagnosis complicated malaria, plenty of Plasmodium falciparum rings smear could be demonstrated immediately. And treated with quinine, mannitol and steroid without any obstetric intervention. We don't want to intervene at 32 weeks at that particular stage for that. And uneventful recovery for that. Pregnancy continuing and then subsequently give birth to normally. So therefore the message, think of medical condition even in labor room. Don't think of only obstetric events for that. Make your brain wider for that also, views wider for that. So appropriate management medically without active obstetric intervention is the treatment in that particular case for that. 30 years old, gravida 2, para 1, living 1 at 38 weeks of gestation with repeated bouts of convulsion and edema, referred from a PHC in a comatose condition. Blood pressure was 220 over 164 millimeter mercury, comatose, urine approximately 100 ml in last 6 hours, urine albumin triple plus. And one diazepam has been given, report discharge ticket and the referral ticket has been given. On examination, I find the uterus stomach size contraction 2 by 10 minutes, relaxation is good, vertex 2 or 4, and cervix fully faced or 5 cm dilated, membrane absent, small caput, pelvis adequate. Now, this is a frank case, undoubted case of eclampsia, and eclampsia being referred from a periphery with a severe hypertension. So, here we can start, give antihypertensive, give anticonvulsant, and expedite delivery for that. That is the 3 fundamental mantra for eclampsia and pre-eclampsia. But the mode of delivery, I think, when the labor process has started, os is 5 cm dilated, cervix fully faced, and a small caput, but at the level of the, below the level of the spine. I think this is important along with the Maxalf, Calcigard. Here diuretics can be given, augmentation of labor. Oxytocin has been given and vacuum application, vaginal delivery can be given. In case it is cervix long or close, there are many cases where the eclampsia is there. There are some debates, there are some papers also that eclampsia, routine cesarean section for that also, for the reduction of the time for that. That is acceptable for that. But if the cervix is not favorable, majority of the cases, the eclampsia, even the cervix is not favorable, make them favorable, put a drip and then early and do it, and the process of delivery continues for that. Otherwise, you can do a cesarean section in that case. And an unusual baby of 1.8 kg with a deep meconium stent like her and Apgar score 8 by 10 was delivered, uneventful recovery, discharged on 10th day. So the message, Maxalf, the ideal anticonvulsant, Modified dose in oliguria you can give it. Antihypertensive as a crisis management, this labetalol injectable can be given or calcium channel blocker. And the main thing is expedite delivery. 35-year-old primary gravida conceived following investigation for primary infertility 10 years, presented at 34 weeks of gestation with edema and decreased fetal movement. On examination, blood pressure was 150 over 100. Uterus 28 weeks, relaxed, cephalic, FHS good. 28 weeks, that's a gross clinical IUGR. Obstetric sonography done, single live fetus, cephalic at 30.2 weeks with gross oligamenous. Estimated birth weight was 1.4 kg. With the gross oligamenous, hypertension, at 34 weeks of gestation. I think what should be done? What should be the obstetric management with that particular case for that? And what is done? Elective CS. I think LSCS was done. Immediate delivery could be done. And if the time permits, you can have a glucocorticoid administration. So therefore, this particular case with the gross oligamenous with an IUGR at 34 weeks, fetus is supposed to be mature. RBS is unlikely for that. And cervix is unfavorable. You have to do the cesarean section immediately with the NICU facilities available with the neonatologist facility available. An estimated IUGR female baby of 1.5 kg with scanty meconium stent liquor delivered. Cried immediately, was kept on parental alimentation for 24 hours in a warmer, gastric lavage, thermoregulation. And the patient was discharged along with the baby. It is a satisfactory maternal and parental outcome was there. Discharged on 7th day, but had residual hypertension post-operatively, for which the antihypertensive has to be continued for a few months. So recognizing fetus is a second patient. Very often maternal-fetal conflict occurs whether you intervene or don't intervene. If you don't intervene, there will be IUFD. Obstetrician's decision of paramount importance here, a delicate balance between the maternal life and the fetal life. An early resort to cesarean section and optimum neonatal care is the theme particularly for this particular case. Problem 7. Primary gravida, 35 years, known hypertensive. Is a known hypertensive before pregnancy, chronic hypertension, and was taking telmisartan SE inhibitor. Presented with first visit at 7 weeks, and blood pressure was 140 over 92 millimeter mercury, urinal urine nil. Sonography demonstrated confirmed there is a single live fetus, 7.2 weeks. So what's your approach? Whether they continue the antihypertensive or not? Case of chronic hypertension, level is a case of chronic hypertension in early pregnancy. Synods are antihypertensive, but selection of antihypertensive. You have to change it. ACE inhibitor are really harmful for the fetus. There are a lot of it, and is absolutely contraindicated during pregnancy for that. So therefore, you have to change the antihypertensive to some other thing for that, selection of antihypertensive. Place of aspirin, now at this particular phase, place of aspirin is optional. You can give aspirin can be given for that. Place of LMWH. I think there is no place for LMWH here because it's not going to help in much better way. Aspirin can facilitate the IUGR, the prevention of IUGR, and for that, because of the class study for that. Routinely also you can give it. In high risk cases, you can give it for that. And place of LMWH is really a debatable issue for that. Now, prevention of superimposed preeclampsia. The marker, you can do it. Early fetal Doppler, which I was telling at 11 to 13 weeks, again, aneuploidy marker, you do it. And PLGF, you can do it. And therefore, fetal Doppler along with the PLGF can predict the possibility of development of hypertension is there. So therefore, aneuploidy screening and preeclampsia screening after 4 weeks is important for the 4 to 5 weeks is important. But all throughout pregnancy, fetal and maternal monitoring should be there and till the delivery for that. Delivery, timing, route and place. Chronic hypertension, if everything is going on normally with antihypertensive, you continue for everything for normal, and there is a place for vaginal delivery, there is a place for spontaneous onset of labor, and preferably don't cross more than 37 weeks term. And as soon as the term is there, you better terminate the pregnancy. And as this particular case, if it is associated with the fetal affections like IUGR and all that, even termination earlier is justifiable for the perinatal outcome. G4P1A2, first and second spontaneous abortion at 8th and 10th week. Third is an IUFD at 34 weeks. History of hypertension during last pregnancy. Last pregnancy, there was reported hypertension and IUFD at 34 weeks. And the patient was not evaluated during the inter-pregnancy interval. She came with the first visit at 6th week for that. Now, what's your approach? Your clinical diagnosis clinches is nothing but APLA syndrome for that. No more APLA positive gives rise to the laboratory criteria, but the clinical criteria are much more important in that. 2 spontaneous abortion at 8th and 10th week where cardiac activity is demonstrated. And third is an IUFD where there is a history of hypertension during the last pregnancy. You confidently say that is a case of APLA syndrome for that. And therefore, at first visit at 6th week, there is absolutely an indication for aspirin and low molecular weight heparin. Had she come earlier, we could have given the aspirin before pregnancy. And here at 6th week also, immediately we start the aspirin and low molecular weight heparin. Don't wait for the cardiac activity demonstration by ultrasound. Earlier it was the theory that yes, in APLA syndrome, actually give aspirin before and do an ultrasound. If the cardiac activity is appreciated, then you add low molecular weight heparin. No more. And place of antihypertensive, yes, place of antihypertensive, you see that whether the blood pressure was there or not. If the blood pressure is there, beyond the cutoff limit, then start the antihypertensive. Otherwise, you can defer it for subsequent weeks for that. ANC protocol normal with the special reference to APLA syndrome for that also. No need of a hypertension if the blood pressure is normal for that. But we anticipate that this time she might develop hypertension and then only we can give hypertension as soon as it is discovered at which period of gestation. So periodic fetal assessment by ultrasound has to be done and maternal assessment as regards development of hypertensive. As the blood pressure, the hypertension develops or proteinuria develops, you add the antihypertensive drugs for that. And duration of aspirin and LMWH, up to which the duration of gestation. This is again a controversial and debatable question before the clinicians. Aspirin and LMWH, up to how much duration? Normally, we use it up to about 34th. In this particular case, 34th week is an optimum time for which you can give it. The indications where there is a previous history of deep vena thrombosis or there is a case where the hereditary thrombophilia, you can continue it till delivery and even postpartum also. Otherwise, routinely, if there is no hereditary thrombophilia or if there is no history of deep vein thrombosis for that, you stop it at the level of the 34 weeks of pregnancy. And timing of delivery depends on you. I see that yes, I don't say that you deliver it at 34 weeks for that also. Continue the pregnancy as long as it is normal for that also. But at least this particular case, the vital period is 34 weeks because the previous history of IUFD is the clinician's viewpoint. The duration at which the IUFD occurred is a landmark, I think, target for that. If it is a 30 weeks, be very cautious about 30 weeks, 32 weeks or 34 weeks. Because it is a 34 weeks, this is a period where you must be very, very vigilant at that particular time for that. And then continue the pregnancy. And timing of delivery is important, mainly on the duration of gestation and the fetal maturity for that also. G2A1, first IUFD at 20th week, cause is not elucidated. We do not know, the patient doesn't give history of any cause for that. Second, first booking at 24th week. And on booking, we find that BP was 140/94 millimeter mercury, urine albumin nil. Sonography, single life fetus 20.2 weeks at gross oligominous. Now the first clinical criteria questions to be asked whether there is a leaking or not. And the patient doesn't give history of leaking. And the approach should be there. That rule out leaking is the first thing. And if it is not there, think about 3 conditions: APLA, SLE, and chronic hypertension. And these are the cases where the oligominous occurs much earlier and hypertension occurs much earlier for that. And prognosis about the present pregnancy. This particular case, prognosis, if the patient will ask, what is the prognosis? I think absolutely I cannot comment on the prognosis. The chances are least. You cannot save this baby for that in majority of the cases for that. And maybe that this early obstetric history, previous obstetric history could be a guide for the subsequent pregnancy. And that pregnancy I can continue and help it with a real the management of if we think that is APLA, the aspirin and the low molecular weight heparin will be given at that particular thing. This particular case, you cannot safeguard the baby, you cannot help that. In place of antihypertensive, aspirin, nitric oxide donor, empirical therapy, antioxidants. Many people give it. Even some people give a amnio sealing the membrane for that also. All these are empirical. Majority of the cases, you don't respond to them. But of course, you have to do a termination of pregnancy here. And after counseling, do a termination of pregnancy. And the patient was not willing, repeat scan after 1 week, IUFD. Then automatically the patient tells that he has terminated the pregnancy. So this is the prognosis of this type of cases for that. Be cautious about it. But this will give a guideline for the next pregnancy to come. We can say that yes, it's a next pregnancy. We can really save the baby. Advice for the next pregnancy for that. Ruling out SLE and chronic hypertension. Establish the diagnosis of APLA and start therapy. APLA protocol of aspirin and LMWH. And you can get every possibility that she will be getting a baby for that. So prognosis for next pregnancy is good because we have already diagnosed, sketch for diagnosis. Problem 10, primary gravida, 30 years, booked case at 28th week. Blood pressure was 144/94 millimeter, bilateral pedal edema, urine albumin nil, fetal parameters normal. Now what is the approach? I can say this as a repetition of this other case, we have similar case, we have done it and all that. Is a case of mild hypertension. Need for diuretics? Absolutely no. Need for antihypertensive? Yes. We can give an antihypertensive, a labetalol or a calcium channel blocker for that. Need for fetal and maternal monitoring? Absolutely yes. Because from 28th week till delivery, we have to continue with this antihypertensive and the monitoring by sonography and all that. And decision for delivery as depends on you. If the blood pressure is absolutely controlled, you can crush the term and wait for spontaneous onset of labor. But if anything deviates from that, either the maternal or the fetal components, you terminate it much earlier. Problem 11. Second gravida, abortion 1, 30 years, conceived following treatment for infertility, normal ANC. Developed hypertension at 38th week. First time it denoted for 38th week. Blood pressure was 140/94. Sonography, high resistance color Doppler, fetal parameters within normal limit, on antihypertensive. Urine albumin was nil. Interval growth scan after 2 weeks, that is on 32 weeks. Sonography revealed single live fetus 31.2 weeks with a brain sparing effect, and AFI was just borderline 8 centimeter. Fetal weight was 1.4 kg, which is relatively and the lesser percentile for that. And blood pressure was little controlled because antihypertensive was given 140/90, but at the time after 2 weeks we find urine albumin was appearing. This is the wrong. I think this is a very adverse prognostic point for that. So now, what is our approach? Need for termination of pregnancy, continuation of pregnancy if you want to, how long we continue for pregnancy. If we terminate the pregnancy for the fetal sake, I think you may lose the baby for that. If everything is normal, brain sparing effect is there, AFI is 8 centimeter, you can wait at least 1 week of prolongation can improve a 5% survival for that also. So continuation of pregnancy is rational, but how long, that will be determined by the fetal factors and the maternal factors for that. You have to reevaluate, need for evaluation, whether need for glucocorticoids, absolutely mandatory. You have to give a glucocorticoids, betamethasone, you have to give it, and betamethasone given 24 milligram, DFMC satisfactory, blood pressure was 140/90 millimeter mercury, but urine albumin was double plus. Repeat sonography after 10 days. Single live fetus, 32 weeks, EFW is 1.5 kg, only 0.1 kg improvement. And there's a diminished end diastolic flow. AFI is coming down from 8 centimeter to 6.7 centimeter. And IUGR, oligoamnios with diminished end diastolic flow. It's not a reversal, but end diastolic flow. Now, we didn't take time to take rest. Plan for termination of pregnancy, and LHS was done. Late preterm IUGR male baby weighing 1.6 kg, delivered. Scanty light meconium stent like on warmer only baby was kept. The baby, we have never shifted to the NICU for that. With warmer, it is absolutely and discharged with uneventful recovery. And antihypertensive continued up to 10 days when the blood pressure was normal, then it is withdrawn for that. Problem 12. Primigravida at 33rd week, booked elsewhere, presented with severe pain, abdomen and bleeding PV. And on examination, I found BP was 150 over 100 millimeter mercury, urine albumin double plus, uterus 32 weeks, 10 tender, and fetal heart was not appreciated. And sonography confirmed there is a case of IUFD and features of retroplacental clot. Cervix was long, os closed, and bleeding PV was continuing. It's more than average for them, and therefore we decided for doing an emergency LSCS. So emergency LSCS was done. Fresh stillborn male baby of 2 kg delivered. The retroplacental clot about 1.5 to 2 liters, and whole uterus was quavellar uterus for that. It's a classical quavellar uterus, and we were thinking of doing a hysterectomy, obstetric hysterectomy, but fortunately, with all sorts of the drugs available, starting from carbitocin to misoprostol to prostaglandins, is managed conservatively. Uterine contraction was optimum, arrest of bleeding was there, and pulse and BP was stable. But urine output was nil. After 10 hours when I saw, there was not a drop of urine in the catheter for the following delivery. And as usual, we give a diuretics, even 4 ampoules of diuretics given, and no response, no improvement in urine output. Blood urea and creatinine was increasing, and therefore we diagnosed as acute kidney injury following placental abruption. Then shifted to ICU. 4 sittings of dialysis was done. Discharged from ICU after 10 days, after 8 days, post-operative normal for that. And what about next pregnancy? It might not recur in the same place, and the mother asked whether I'll be a mother or not, and whether the same thing can occur or not. It's an acute kidney injury which has revived, and absolutely normal renal functions will be there. It's a chance recurrence for that, and preventive strategies, nothing is important for that also, excepting giving the aspirin for that. And preventive criteria, you have to, this is a really a predictive scoring for that. This is likely to have developed the same thing. And preventive, right from the beginning of pregnancy, you continue with that. Even I will just say that yes, these are the cases you can give the combination of aspirin plus LMWH for that also. There is a place for that here. And modalities of ANC should be very important, and be careful at 32 weeks for that also. And therefore, these are the cases you continue whole of the pregnancy monitoring and deliver it as soon as some fetal problem will occur and all. Elderly primigravida, 38 years, conceived following IVF-ET, twin pregnancy, conventional ANC, developed hypertension in early mid-trimester. On antihypertensive, fetal monitoring normal, had PPRM at 35th week. First was bridge, second transfers. Emergency LSS was done. Twin fetuses, first male, second female baby, weighing 2.2 kg and 2 kg respectively delivered. Uneventful intraoperative period, but post-operatively, on the second day, developed severe dyspnea. Severe dyspnea, she developed it. Blood pressure was 150 over 100 millimeter mercury. SpO2 was falling down, not responding to conventional treatment. Now, you think of some ailments. Echocardiography was done, and on echocardiography, we find a peripartum cardiomyopathy with ejection fraction, gross reduced ejection fraction about 28%. Put on dobutamine and diuretics, and patient improved after 48 hours in consultation with the cardiologist and all. Discharged on 10th postoperative day. So what we learn? The message is that peripartum cardiomyopathy is not uncommon in current situation. 38 years. Now the social demography has changed for that, and therefore chronic hypertension, diabetes, associated obesity, associated with it in the late age, peripartum cardiomyopathy. Don't Ignore that entity. It's not uncommon. Remember that. And from that time onwards, I always preach to do a routine echocardiography in pregnancy. In long-standing hypertension, it is a mandatory thing. In hypertensive disorders of pregnancy, if it is a long-standing hypertension, do a echocardiography in pregnancy to rule out the peripartum cardiomyopathy for that also. And you have to be very cautious about it. Where in the last moment, I found out that this is a case of diagnosis with the priming gravida book case on antihypertensive for gestational hypertension. Normal fetal parameters. At 36 weeks, presented with reeling head, decreased fetal movement. Blood pressure was 170 over 110 millimeter mercury, albumin triple plus. Again, same thing approach is a severe hypertension, a fulminating variety of hypertension. This is not unusual also nowadays. Even with the standard antenatal care with the booking also, you may face at a time when the patient presents. You are booked from the beginning of pregnancy, she was under you. But all of a sudden, this is there for that. Selection of antihypertensive, again, I have dealt with that. Need for anticonvulsants, absolutely mandatory. Need for glucocorticoid, really important for that also. Need of other tests like liver enzyme, platelet count, and all that. But glucocorticoid, if time is there, you apply. Otherwise, if it's an emergency termination is indicated, even we can ignore the glucocorticoids for that. So decision for delivery has to be done. And live male baby of 2.8 kg delivered on eventful recovery for that. And the message here is a fulminant preeclampsia is not uncommon, and we have seen anticonvulsant and antihypertensive treatment are both mandatory supportive therapy, and immediate delivery saves lives of mother and baby and the obstetrician also for that also. And this is the last slide I can put you. Still it is there. This is not a new slide of mine. It's already there. Placards honoring names of famous obstetricians adorn the Chicago lying in hospital. And the four it has been written, the four obstetricians, great obstetricians, starting from Palfin to the Sutherland and all that. But the central empty space is reserved for the scientists who discovered the cause of preeclampsia. Decades and decades after that, with a lot of researchers also, till date, we're not able to find out. And still, this space is left behind. I wish any one of you can try and find out to have a space there in the Chicago Lining Hospital to honor you for that. Thank you very much, ladies and gentlemen, for giving me this opportunity. And thank you, the Georgia team, with all enthusiasm, Alad and Sanjay and the whole team and conference team. I think I thank everybody for that. They're giving me a chance as a teacher. It's one of the greatest satisfaction of mine to teach people. I'm an expiry date teacher, retired since 2018. And therefore, I thought this is a passion of teaching, is a passion for me. And therefore, you have given an ample opportunity to give a link between my students. They are my property. And therefore, I'm emotionally connected to each one of them. And therefore, you have given a chance to me for this particular episode and waiting for the next episode. And this every month in this third Thursday, we will do that so that our viewers will not confuse and they will note down for that also. Thank you very much.
Sir, there are many comments honoring you. I will just read few comments and then we will take the questions. Dr. Tapas Goswami, he is saying knew almost all of it, but dust gathered in all these years. Your talk helped in brushing all of the dust. Thank you, sir. Thank you very much, sir.
Thank you. Thank you.
So, sir, wait sir. We will. Uh,
Clinician's viewpoint, I just circulated this.
yes. And sir, I want to tell that more than 600 live users are there. More than 600 gynecologists are listening to you.
Thank you. Thank you. I thank all of you, all of the Jorbia team for that.
Yes, sir. And sir, with your permission, we will take few questions from them. So, Dr. Archana Kiran Marathe, she is from Maharashtra. She is asking, is bed rest indicated in PIH?
That was there. Bed rest. What is meaning by bed rest? Rest and bed rest are completely two different. And bed rest means completely lying in the bed. I don't want to immobilize my patients for that also. And bed rest is important. Yes. It's about a couple of hours rest, 8 hours rest is important, 6 hours minimum in the night, 2 hours in the afternoon is important for them.
Yes, sir. Sir, the next question is from sir Dr. Pawan. He is sharing his experience. This is based on his last episode, your last episode. So he is saying how to avoid amniotic fluid embolism because prophylactic low molecular weight heparin is there for DVT. But what about amniotic fluid embolism, sir? I have two patients during residency, both succumbed and felt very bad and could not sleep at that time.
Mm.
Thank you very much for this, a very tricky question. And believe me, amniotic fluid embolism, when we do not find any cause of death in obstetric patient, more so during the time of delivery and immediately delivery, we'll have it as a case of amniotic fluid embolism, but these are not. Amniotic fluid embolism, the diagnosis must be on autopsy. Suppose in lungs you find an amniotic material, then only it's amniotic fluid embolism. Just by the clinical findings of a shortened gas and dyspnea, breathlessness, and patient gasping, these are not true amniotic fluid. This can safeguard in the court of law, but to diagnose amniotic fluid embolism is a tricky question. But I can say that you have seen two cases. I have also seen number of cases for that, and these are all cases of pulmonary embolism because of the deep vein thrombosis. I think venous thromboembolism is most important for them. And these are the cases which are ignored. Earlier we were telling that yes, this was, we do not find in India venous thrombosis. And in Western countries, this is a thing which is hereditary, genetic, and other relationships are there. But still, I can say that in India also, and particularly in this particular setup, when the hemorrhage, hypertension, and sepsis has declined, these has come up in a big way for them. And therefore, not only in obstetric practice, but in gynec practice, I have also perioperative, I think, role of perioperative thromboprophylaxis is mandatory. And believe me, sir, I have the practice for the last few years that I routinely give a thromboprophylaxis, LMWH, for 5 days during the perioperative period. You do a surgery and then for 5 days, 40 BD is enough. For 3 to 5 days, you give it for that. And that will prevent this type of embolism, not amniotic fluid embolism, but pulmonary embolism. And this pulmonary, once it is there, is a massive pulmonary, you cannot save the patient. So prevention is very important for that also. And even in a mild variety of embolism, I have started that and got a good result for that also. And therefore, think of this particular case, even if it's a dyspnea, that particular case which I was thinking peripartum cardiomyopathy, I was thinking also about embolism for that also. If the cardiac status would have been normal, I would have put the amniotic fluid, I think the LMWH for that also. Once I found that it's a case of cardiomyopathy, my diagnosis is confirmed for that. And therefore, ladies and gentlemen, it's a point you remember that perioperative thromboprophylaxis, you give it routinely, and it's my protocol. Maybe that you can accept that. Patient weighing 90 kg, more than 90 kg, all cesarean or operative delivery or the vaginal delivery also, more than 90 kg in obstetric patient, I always put the thromboprophylaxis the day of surgery. I do the surgery and start that immediately for that. Many people say that you give beforehand. Beforehand, there could be a chance of bleeding and all that. I don't give beforehand. They completed the surgery, more than 90 kg, routinely you give it either an obstetric patient or a gynec patient in a pelvic surgery also. Second important, the duration of surgery. If the duration of surgery is more than 2 hours, I usually give it for that. And therefore, it's absolutely mandatory for that. Then radical surgery, an extensive pelvic surgery. These are the indications where you give a prophylactic thromboprophylaxis. An obstetric patient, take care of the weight. If the weight is more, even if everything is normal, you put it, you are safe.
Yes, sir. Yes. Next question is from Sureka Jain. She is asking, sir, in case of severe hypertension, IV labetalol can be added with nifedipine. How and what dosage?
No, IV labetalol, if you compare, the hydrogen has been superior, but unfortunately, you people are not marketing that. And labetalol parenteral is inferior to the hydrogen, but superior to oral labetalol for that. So that in the case of a labetalol, we give it, and majority of the obstetricians switch to prefer calcium channel blocker for that also. And calcium channel blocker is also a very good drug for emergencies also. But don't give the sublingual thing.
Yes, sir. Yes. Dr. Minal Ramaya, she is asking, is APLA apply hereditary?
No, it's not hereditary. Apla is not hereditary, but it's not a genetic condition. It is an immunological phenomenon. So apply is an immunological phenomena, and that is linked either a clinical profile, clinical criteria, or a laboratory criteria. Laboratory criteria becomes very difficult because inter-laboratory variation, you have to repeat that test at 12 weeks interval. And clinical criteria for clinicians are much more important for that also. And we use this clinical criteria, the Sydney criteria, modified criteria for that.
Yes, sir. Dr. Ashok Mishra, he is asking, sir, how to go ahead with PID? Nowadays, more cases are increased.
So from obstetric part, you have from PIH to PID. Pelvic inflammatory disease, I suppose for that. Of course, it's not this particular episode. I will tell you. PID, pelvic, again, it's a misnomer for that also. Any patient with a pain abdomen, gynec patient with pain abdomen, we level the case of PID. Now, classically PID, there are CDC criteria for PID for that also. So minimal criteria and a major criteria for that. So pelvic inflammatory disease, the CDC criteria we adopted for that, and just finding out the some of the signs like the cervical motion tenderness, pharyngeal tenderness, and combined with the ultrasound has become a great part to differentiate it from endometriosis, from a TO mass for that, and that is a separate chapter by itself. And whether you give a domiciliary, there are some indications, and institutional, there is some indications for that also. And diagnostic criteria, clinical criteria, sonography criteria, and a laboratory and the laparoscopic criteria. These are all evidences for that also.
Yes, sir.
We
Sir,
will
next.
one episode I will deal PID also.
Okay. Yes, sir. Yes, sir.
Yes.
Sir, next question is from Dr. Vidya. She is asking, how can we prevent collapse of patient on operation table?
Collapse of patient on operation table, you find out the cause of collapse of patient by operation. Is it a hemorrhagic, or it is some anesthetic accident for that, or is it some neurological problem or a cardiac problem for that also? You have to find out and deal with that. But remember, majority of the obstetrician are having a hemodynamic collapse because the hemodynamic factors, because of the hemorrhage, they collapse occurs for that also, and hypertension occurs. I always say that hemostasis to the surgeon and oxygen support to the anesthetist. If these two are carried out in OT, there won't be any intrapartum malady for that also. These two are very important for that.
Yes, sir. Next question is from Sri Lakshmi Ambarkar. She is asking prophylactic LW, the low molecular weight heparin, when to start in post-operative period.
Post-operative, immediately the day of surgery, you finish the surgery and start it. There's no problem for that. Even these type of cases, a prophylactic can be started just half an hour to 1 hour before surgery also. But most preferably, immediately after surgery, I start it.
Okay. Yes, sir. Sir, next question is from Sneha Tedu. She is asking best oral antihypertensive immediate post-delivery, whether labetalol or nifedipine.
I think nifedipine has most often been used by all of us. Labetalol is used during pregnancy, and immediately after delivery. If says using labetalol, you continue the labetalol for that also. There's no problem for that. Both are equally good for that.
Yes, sir. Next question is from Dr. Vinita Gokru. If clinical criteria for APLA are present, do we still need to confirm it by lab test?
Never. Even if APLA lab test is negative. You see many cases which clinical criteria is there. and lab test applies negative, you have to start the believe on the clinical criteria and start the aspirin and normal treatment. Don't depend on the laboratory test.
This similar. She is asking if clinical criteria for APLA are present. Same question, sir. The next question is from Dr. Sushmita Mishra. If APLA is positive in interpregnancy period, when to start LMWH?
As soon as the pregnancy is positive, you start. Say missing period 1 or 2 days, beta ICG positive, you start immediately. Don't wait for the cardiac. Gone are the case where we the normal, some of the textbook also write that you start aspirin pre-conception and add LMWH when the sonography demonstrates cardiac activity. But no more. You start earlier also, because many cases we save the pregnancy also for that. What we do, that same cases, the fertility specialist, the ET, day of ET, they start this LMWH with that also. Same thing. Here there is no question of delaying it. You start it right when the pregnancy becomes positive, and beta ICG positive or urine test positive, you start immediately.
Yes, sir. Thank you, sir. Thank you, Dr. Mahapatra, sir, for extremely insightful session on hypertensive disorders of pregnancy. On the behalf of Zorvia Healthcare, I sincerely thank you for sharing your knowledge and experience with fellow gynecologists. Thank you, sir. Thank you very much, sir.
Alad has joined. Thank you.
Yeah, we have
Thank you, sir. Thank you.
we have with us. Yeah.
Thank you so much, sir, for your time. We are really
Thank you.
indebted. Thank you so much.
You become spirited so that you came running to join me. Thank you very much again.
Thank you.
Samir,
Thank
please
you.
stop the recording.
Because
Yeah.
Alad Mahajan, this is an idea of Alad Mahajan. Full
Arre,
credit
no,
to
sir.
Alad Mahajan.
No, sir. It is